tomorrow. Okay, images भी हाँ. So I have sent image वाला PPT to everyone on the Telegram group है ना. So आप वो images अच्छे से बिल्कुल समझ के लिखना है, उनको अपने दिमाग में फिट कर लेना. ये images तो हैं ही हैं. Okay. Tomorrow नहीं, we won't be able to finish tomorrow. No, day after tomorrow also will have few hours that will finish on Thursday. ठीक है, कल finish नहीं होएगा. No, Dr. Murthy, tomorrow is not the last class. Okay, day after tomorrow, Thursday, will be finishing. चलो guys, so any doubts first of all before I want to start the class? Any doubts? कुछ भी पूछना है आपको? Any weird question? Anything which is crawling your mind? कुछ पूछना है बच्चे? Any doubt? Any problems? Okay. चलो तो फिर हम स्टार्ट करते हैं. मुझे बताओगे कुछ? मुझे बताओगे where do you get Stoker's line? Where do you get Stoker's line? कल हमने 2 लाइन्स पढ़ी थी. We read 2 lines yesterday. One was Stoker's line. What was the other? Yes guys, anyone? कहाँ गए? Yes, we read Art's line. ठीक है, we read Art's line which was in trachoma. We read Stoker's line which was in pterygium. ठीक है, Art's line is a line of scarring. Stoker's line is a line of iron deposition. Okay, चलो, good guys, good. चलो तो आज हमें पढ़ना है. We will start with viral ulcers today, or we can say viral keratitis. ठीक है. So 2019 में guys twice you have questions from this topic, viral keratitis. हर साल अल्सर पे क्वेश्चन आ रहा है. Every year you are getting a question on ulcers. So ulcers is a very important topic in cornea. Okay, cornea itself is a very important topic. Investigations हैं, so many picture questions are there. Keratoconus पे questions हैं. So it's very important topic for ophthalmology. Now guys, viral keratitis में we have to read 2 types of virus. The first one is a herpes simplex virus. The another one will be your herpes zoster. So पहले हम herpes simplex के बारे में पढ़ेंगे. Herpes simplex virus. Okay, this is the first what we have to read. Now guys, herpes simplex causes 2 types of keratitis, 2 types of corneal ulcers. The first one is called as the dendritic ulcer, and the questions are mostly on this. Okay, so this was the question asked to you in 2019. The first ulcer is dendritic ulcer. Now guys, this dendritic ulcer is very special. Try to understand. It's difficult to see this kind of ulcer with a naked eye. Okay, naked eye से ये ulcer नहीं दिखता. So you need a slit lamp first of all to diagnose. You need a slit lamp. Now when you see the patient on slit lamp, you will find out this kind of pattern. Please appreciate. 1 से 2, 2 से 4, something like that. So this is a branching kind of pattern. This is called as a dendrite. Okay, so this pattern if you see on slit lamp, and characteristically a true dendrite will have knobs. A true dendrite will have terminal knobs. Can you see guys the knobs at the end? आपको knobs दिख रही है बच्चे? ये knobs दिख रही है? So this is the characteristic of a true dendritic ulcer. ठीक है? So you see a branching pattern with knobs at the end. This is characteristic of dendritic ulcer. Now, I told you that you have to see the patient on slit lamp. And on slit lamp, you have to stain the cornea first with fluorescein dye. आपने patient को slit lamp पे बिठाया, एक fluorescein dye करके होता है. भैया ये green color का उठाओगे पैकेट, green packet. See guys. This is your fluorescein dye. Kindly see. देखो इधर, everyone. So can you see this orange color dye? This orange color dye is your fluorescein dye. This is another picture question. Please don't forget. ठीक है, ऐसे orange strip दे सकते हैं. वो पूछेंगे ये क्या है? So this is your fluorescein dye. Okay. Now you will put the fluorescein dye in the conjunctiva and ask the patient to close the eye like that. ठीक है? तो क्या होएगा? It will spread on the tear film. Okay, so your tear film will be orange in color. Now, okay, so this will be orange in color. Orange color dye you will put on the cornea. Okay, now what will happen? You will turn on the blue light of slit lamp. you will turn the blue light of slit lamp. So what will happen? You will find out that this lesion will turn green in color. Okay, देखिए आप कितना सुंदर डायग्राम है. All of you please see. Please see, this is a characteristic dendritic ulcer, characteristic of a herpes simplex virus. Guys, can you appreciate this green color lesion? तो ये actually green नहीं है. ये green क्यों हुआ? Because you have stained this with fluorescein dye. So my question is, what is the property of this dye? The property of this dye is that it stains. It stains ulcer in green color. Any ulcer or any epithelial defect. Okay? If you have any epithelial defect in the cornea, it will be stained green in color. Now, when you see this morphology is typical for dendrite. Am I clear, friends? It's clear? ठीक है, सबको समझ में आ गया? Now, suppose there is an ulcer like that. Suppose there is a bacterial ulcer. है ना? Suppose there is a bacterial ulcer here. Now, when you stain this with fluorescein dye, what will happen? This whole area will turn green. But this is not a viral ulcer because it does not have a dendritic morphology. If you see this morphology, that means this is your dendritic ulcer caused by herpes simplex virus. Okay, so there are so many questions. नहीं बेटा, no foreign body, no. Dr. Mohanty, foreign body will not be stained. Only a defect in the epithelium will be stained green. A defect in the epithelium or any ulcer, because ulcer itself also is a defect. समझ आ रहा है बेटा? Orange color is the dye. Dr. Akshata, orange color is the color of the dye. And what is this blue? ये blue क्या है? ये blue is the light of the slit lamp. Now is it clear, everyone? So don't get confused again. Orange color is the color of the dye. Blue is the light of the slit lamp and green is the ulcer. Now is it okay to everyone? ठीक है बेटा? Now my question, very important. How are you going to treat this ulcer? So you will give antiviral agents and you will give acyclovir ointment. This is the drug of choice. ठीक है? Acyclovir ointment is the drug of choice. Question very frequently asked. Acyclovir का ointment देते हैं. Drops are not available in the market. Okay. Now, please remember a $1 million question. Steroids are absolutely contraindicated. Absolutely contraindicated. Why? Because if you give steroids, there can be a perforation. This all dendritic ulcer will join each other to cause a perforation, or it may also result in the next ulcer called as geographical ulcer. ध्यान से देखिए बच्चे. So I told you the first ulcer is dendritic ulcer. But if you happen to give steroids, these all dendrites will join each other and it will result in a big large ulcer, and that ulcer will be a geographical ulcer. ठीक है? This is a huge big ulcer. Okay, so you can say yes, only topical ointment. Orals are not required, Dr. Harjot. Oral acyclovir is not required. Okay, so when I ask you what two types of ulcers are caused by herpes simplex, you have to say dendritic and geographic. Okay, you have to say a dendritic ulcer and a geographical ulcer. They simply can ask you geographical ulcer is caused by which organism, so you have to say herpes simplex virus. ठीक है बच्चे? The next is herpes zoster virus. Now let us see what are the manifestations of herpes zoster virus in eye. What can herpes zoster cause to your eye? So the first very important question is, it can cause a pseudodendritic ulcer. Pseudodendrite. अब pseudodendrite से क्या समझते हो? What do you understand by this word pseudo? Pseudo means that it has branching pattern, but what does it not have? What does it not have? No terminal knobs. Very good. The terminal knobs are absent. Very good. ठीक है? True dendrites were having knobs, but pseudodendrite does not have a knob. So this is a very important question. Simple. Pseudodendritic ulcer is caused by, answer is herpes zoster virus. ठीक है बेटा? Very simple. Next important question is nummular keratitis. Nummular. Nummular keratitis. Nummular keratitis means that it will give you small point shaped lesions, point shaped ulcers. ठीक है, point shaped ulcer, nummular keratitis, nummular. ठीक है, simple question है, पूछते हैं ये भी. Now here comes the very important question, herpes zoster ophthalmicus. ठीक है, इस पे बहुत बार क्वेश्चन आया हुआ है बच्चे, herpes zoster ophthalmicus. Now I'll show you a picture first and then I'll explain what is this herpes zoster ophthalmicus. ठीक है, आप लोग को चिकन पॉक्स तो हुआ होगा, you must have got chicken pox in your childhood, है ना, चिकन पॉक्स. So chicken pox is caused by the zoster. Now zoster is where is your zoster virus now? Zoster virus is there in the trigeminal ganglia. ठीक है, it's resting there in the trigeminal ganglia. Now when you become immunocompromised or when you have an uncontrolled diabetes, severe viral infection or any kind of immunocompromised state, your virus can get activated and then it will come down. Suppose it comes down through the trigeminal nerve. Look at me everyone. Suppose it is coming down through the trigeminal nerve and this time it has gone towards the ophthalmic division of the trigeminal nerve. And from the ophthalmic division it has also gone to the tip of the nose. So please see this picture guys. What has happened here? This time the virus has come down through the trigeminal nerve and from the trigeminal nerve the ophthalmic division. From the ophthalmic division the nasociliary branch is affected. Are you able to understand? So now can you see all the vesicles are there on one side of the face? Vesicles है ना one side of face पे, and you can see the tip of the nose is also involved. So herpes zoster ophthalmicus follows Hutchinson's rule. What is Hutchinson's rule guys? Hutchinson's rule predicts ocular involvement. It predicts ocular involvement. How? It says if you have vesicles on tip of the nose, your eye will also get affected. Are you able to understand that? If tip of the nose has vesicles, eye involvement will be there, will be positive. Now can anybody tell me why is this so? Why is this so? Why? Anyone? Why does this happen? It's because of the involvement of the nasociliary nerve guys. Nasociliary nerve. You know the nasociliary nerve causes, it supplies the tip of the nose and it supplies the cornea both. Okay? So if nasociliary nerve is involved, your cornea will also get involved. Okay? So there are so many questions guys. Last year they had given you herpes simplex. This time they can give you this picture and they'll ask you which rule is this, which pathology is this, which nerve is involved, and what is the treatment? Anyone, what is the treatment? The treatment is again acyclovir, but this time oral acyclovir. ठीक है? क्या दोगे आप? You will give oral acyclovir. Okay? Topical will not help much. You have to give oral acyclovir. This is the drug of choice. Okay, बच्चे? So this is about your herpes zoster and herpes simplex. Now, a very important thing about viral keratitis. Very, very important. So these viral ulcers, ये जो viral ulcers होते हैं बच्चे, these viral ulcers are famous for their recurrence. These are recurrent ulcers. First of all, these are recurrent ulcers. Whenever you are immunocompromised, suppose you have any fever, any viral illness, these ulcers can come up again and again. Second important thing is that they decrease the sensations of the cornea also. Okay? They decrease the sensations of cornea also. So there are two things about virals. These are recurrent ulcers and they cause decrease in sensations of the cornea. Post caused hepatic neuralgia. हाँ, they can cause so many other things also. ये मैंने पढ़ाया ही नहीं है because आप ये medicine में पढ़ोगे and derma also you will read this detail in derma and in medicine. Herpes can cause so many things, not only the corneal involvement, it can cause your scleral involvement, optic nerve involvement, है ना? It can cause problems related to conjunctiva, uvea, anything, anything. Do you want to write this, Dr. Waghela? ठीक है? No. This one? So we have done viral ulcers also, guys. Now we will read something about acanthamoeba ulcers. Acanthamoeba ulcers भी बहुत important है. In 2019 again you had a question from acanthamoeba. ठीक है? चलो acanthamoeba ulcers पढ़ते हैं. So first of all tell me what is this acanthamoeba? ये acanthamoeba है क्या? What is this acanthamoeba? So this is a free-lying protozoa. है ना? It is a free-lying protozoa. Where does it stay? So it stays mainly in soil. है ना? It's not a fungus beta. It is a free-lying protozoa. Dr. Rukhsar, fungus नहीं है बच्चे, ये protozoa है. Now, if it is in soil, how does it come to my eye? अगर ये soil में रहता है तो ये मेरी आंख में कैसे आया? So it is mainly used by the contaminated water. पेशेंट की बड़ी मजेदार हिस्ट्री होती है. क्या हिस्ट्री है? डॉक्टर साहब मैं तो बिल्कुल ठीक था, मैं सिर्फ गंगा में डुबकी मारने गया था, है ना? यू नो गंगा इज लाइक वेरी पायस, है ना? सो पीपल गो टू गंगा, अपने पाप धोने के लिए चले जाते हैं और वहां से acanthamoeba ulcers लेके आ सकते हैं. यू नो हाउ प्योर गंगा इज nowadays. Okay, so you can have history of swimming in dirty water, as Dr. Raj has told us, swimming in dirty water. And very important is when you have a contact lens misusage. What do you understand by contact lens misusage? Suppose if you are using a contact lens and you have used tap water to clean it, or you have used dirty water to clean it, so you can have washed not with the proper solution, then contact lens misusage can also lead to acanthamoeba ulcers. But mind you, the most common ulcer in contact lens users is not acanthamoeba, it is pseudomonas. I hope you remember that. Yesterday we have read this. जो लोग कॉन्टैक्ट लेंस को यूज करते हैं उसमें ज्यादा चांस सूडोमोनाल अल्सर होने के हैं. ठीक है? Please remember this fact. It is an important MCQ. Now, when you see these ulcers, their clinical features are also very different. So what is the first thing? These ulcers are the most painful ulcers. Can anybody tell me why? These ulcers are the most painful ulcers? Why? Now let's go back to the yesterday's class. Yesterday we have discussed that the pain in patient of corneal ulcer is because of the ciliary spasm. Do you remember? There is a ciliary spasm. But what is happening here? Apart from the ciliary spasm, the acanthamoeba directly causes the inflammation of corneal nerves. And this condition is called as radial keratoneuritis. What do you call it? Radial keratoneuritis. The word neuritis means inflammation of nerve. The word kera means cornea. तो ये acanthamoeba क्या करता है? डॉक्टर प्रियम ने बिल्कुल सही बताया. One is it causes a ciliary muscle spasm. The next thing is it causes a direct inflammation of the corneal nerves. That is why there is a lot of pain, and hence this is a question. They ask you radial keratoneuritis is a feature of. So you have to say it is a feature of acanthamoeba. ठीक है? Apart from that, this ulcer is very difficult to diagnose. Why? The problem with this ulcer is that it mimics the other ulcers. It mimics other ulcers. मतलब sometimes it looks like a dendrite, sometimes it looks like a ring, sometimes it has amoeboid shape, so you get confused which ulcer is this. ठीक है, कभी लगेगा कि डेंड्राइटिक है, कभी लगेगा रिंग अल्सर है, तो फंगल है. So this is, a difficult diagnosis, right? Now the treatment is also different. The treatment is PHMB, biguanides, polyhexamethylene biguanide. ठीक है, polyhexamethylene biguanide, or you can say biguanides are the drug of choice. Biguanides are the drug of choice. Okay, I'll show you a picture which has a acanthamoeba ulcer. Just finish writing here. ठीक है, let me show you a ulcer here. देखिए इसको. So this was a patient who has a history of contact lens misusage. Can you see a ring shape ulcer? अब ring है तो आपको लगेगा कि ये fungal है, but no, this time it is acanthamoeba. Okay, so it's kind of mimicking the other ulcers. Okay, चलो अभी next ulcer पढ़ते हैं. So the next ulcer is interstitial ulcer. The next ulcer is interstitial ulcer. Interstitial ulcer या फिर interstitial keratitis. So what do you mean? Dr. Shubham, the history is the most important thing. ठीक है, history is the most important thing. When you have a history of a contact lens usage or the history of bathing in dirty water, then you have a high level of suspicion. Otherwise, you do a scraping, you send the specimen, and when you see a acanthamoeba trophozoids, then it will be diagnostic. Okay, but definitely we start the patient on antibiotics first. Okay. Now the meaning of interstitial keratitis is that this is a stromal ulcer. ये बहुत ही special ulcer है, बच्चे ध्यान से समझेंगे. Now guys, we have learned that the ulcer occurs when you have a defect in the epithelium. Yes or no? जब तक defect नहीं होगा epithelium में, microorganism कैसे आएगा? Now this is a special ulcer where the epithelium and endothelium of the cornea both are normal. Only the problem is in stroma. So how is it possible? Organism कहीं से तो आया होगा ना, या epithelium से या अंदर से, है ना? So this is a very special kind of ulcer where both the epithelium and endothelium of the cornea are normal. This is the problem only in stroma. So this organism has come from immunological response. This is a kind of immunological ulcer. ठीक है, somebody was asking me a painless ulcer, so this is one example. Stromal ulcers are generally painless ulcers, immunological ulcers. Okay, now usually you can see this in syphilis. Usually syphilis is the most common cause of this ulcer. बहुत बार पूछते हैं. And as a clinical feature in the cornea you see a salmon patch. What is this salmon patch guys? ये स्ट्रोमा के अंदर एक पिंक कलर का टंग शेप पैच होता है. It is a tongue shaped patch in the stroma of the cornea. Salmon patch. ठीक है, tongue shaped pink color stromal patch. Because the problem is only in the stroma, so you will have a tongue shaped salmon patch in the stroma. Okay, please remember, important question. Now the next type of ulcer which we are reading is the trophic ulcer. Trophic. अब ये trophic से क्या समझते हो guys? What do you understand by the word trophic? Trophic ulcers can be divided first of all into two broad categories: a neurotrophic ulcer and neuroparalytic ulcer. Neuroparalytic ulcers. ठीक है? Neurotrophic and neuroparalytic. Now before I make you understand this, let us see a picture and discuss the ulcers with the help of the picture. Please see what is happening. What is the problem here in the picture? क्या परेशानी है इस पेशेंट को बताओ. Okay, which is the abnormal eye? Which palsy is this? Left eye is normal. मैं बताती हूँ, देखिए. So this condition is called as lag of thalamus on the right side. This eye is a problematic eye. So what is the problem? Don't confuse this with ptosis. Dr. Priyanka, बेटे देखो इधर. So here the right eye is abnormal. This is called as drooping of eyelid. ठीक है, every student get confused here. Ptosis is not same as lag of thalamus. In ptosis, right eye is not able to lift up properly. In lag of thalamus, the patient is not able to close the eye completely. Now I am clear? Is it clear to all of you now? Whenever you are in doubt, look at the normal eye. Left eye is closing properly. Here left eye is opened properly. ठीक है बच्चे, कंफ्यूज नहीं होना है. That's why I always keep the two photos together. ठीक है. Now think about it and tell me which muscle closes my eyelid. Quick answer. Anatomy हो गया है ना आपका. Which muscle closes the eyelid? Yes. ओए होए, नहीं बेटा, आपका हो गया है ना सब anatomy का ये. Your anatomy is done. Tell me. Orbicularis oculi. Dr. Yogita Raj is absolutely right. So it is orbicularis oculi which closes the eye. जो आप आंसर बता रहे हो, that is levator palpebrae superioris. That is for opening the eye. Look at me now again. When I close my eye, it is mainly by a circular muscle here, which is orbicularis oculi. When I want to open my eye, when I want to look up, it is by levator palpebrae superioris. Is it clear to you now? ये सबको ठीक है, समझ में आता है? ठीक है, चलो तो अब देखिए क्या हो रहा है. So this closure is because of the orbicularis oculi, and orbicularis oculi is supplied by the seventh nerve. So whenever you have a seventh nerve palsy like Bell's palsy or any other cause where your seventh nerve is damaged, so obviously your orbicularis oculi will not be contracting properly. So there will be problems in the closure of the lid. Okay. Now suppose if this child sleeps, obviously he'll sleep for 8 to 10 hours. So what will happen? His inferior cornea will get exposed. Isn't it? This inferior cornea will get exposed, and because of the desiccation, because of the dryness, there will be an ulcer. Okay? So you can write down something about the neuroparalytic ulcers. Neuroparalytic ulcers is because of the paralysis of seventh nerve. Paralysis of seventh nerve. Why? So it's because of the paralysis of seventh nerve. So paralysis of seventh nerve leads to problems in orbicularis oculi. Your orbicularis will not be able to contract. If your orbicularis is not contracting, it will lead to lag of thalamus. Okay, what is lag of thalamus? Inability to close the eyelid. Okay, inability to close the eyelid, and because of that, what will happen? You will have the corneal exposure, and because of that, the ulcer is called as the exposure ulcer. It is another name for neuroparalytic ulcer. Am I clear, friends? I'm not able to access with the chat here. भैया chat box नहीं आ रहा है शायद. Chat box नहीं आ रहा है मेरा. बात करो ना. अच्छा. Okay, is there any problem? Is this neuroparalytic ulcer clear? Now the second type of trophic ulcer is a neurotrophic ulcer, and this is because of paralysis of the fifth nerve. Your fifth nerve gets paralyzed, and fifth nerve, you all know, it gives sensations to the cornea. So if there is no sensation to the cornea, what will happen? If this is deprived of, cornea is deprived of the sensations, what will happen? And now there is no sensation to the cornea, so what will happen? You don't feel anything. If something is there on the cornea, you won't be able to feel, and then you are more prone to get ulcers. ठीक है? इसका क्लासिकल एग्जाम्पल है, आपने डायबिटिक फुट देखा है, डायबिटिक फुट, या फिर पेशेंट हु हैज अनकंट्रोल्ड डायबिटीज, यू मस्ट हैव सीन that these patients have foot ulcers, sole ulcers. Why? They have sole ulcers. Why? Because they have neuropathy. They don't feel anything. If they don't feel anything, they will be moving on something like pebbles, but they are not feeling anything, so they get ulcers. Same thing happens in the cornea. If there is no sensation, you are prone to get ulcers. Neurotrophic means paralysis of fifth nerve. Neuroparalytic means paralysis of seventh nerve. Is this clear? ठीक है बेटा. So how will you prevent? How will you prevent, or how will you treat this exposure ulcer? How will you treat? I don't want cornea to get dry, so I will give lot of tear supplements, isn't it? I don't want the cornea to get dry. What else I can do? I can patch the eye. When the patient sleeps, I can patch the eye. ठीक है? So please remember, these two questions are also very important. How to treat the neuroparalytic ulcer. Okay? Tear supplements and patching of the eye. How to patch? Cotton patches आते हैं बेटा. Cotton के ऐसे white color के जो पट्टी नहीं होती, पट्टी. You can put that. Okay? Chalo guys, let's do few questions. We are done with corneal ulcers. Let's quickly revise them. Yes, you can also put pyrate patches. See, white color की पट्टी नहीं होती, छोटे उसके patches बना के you can put a tape here. Okay? No, for the nerve, for the sensations, you cannot give back the sensation. So you just have to put a lot of tear supplements. Okay? Who said B? Dr. Anuj, Dr. Kishore, तुम्हारी पिटाई करेंगे हम. क्यों? क्योंकि herpes simplex नहीं है, ये तो herpes zoster है बेटा. So please see this question. This is typical of herpes zoster ophthalmicus, not a herpes simplex. Okay, so this, you know, the history is very typical. You have uncontrolled diabetes and hypertension, right? And you know, oral acyclovir is the treatment. But what about the nerve here? The nerve is not frontal, the nerve is the nasal ciliary nerve. And rash will not disappear in 2 days. Guys, it takes at least 7 to 10 days for the rash to get down, and it takes almost 2 to 3 weeks for the rash to get disappear. ठीक है? Is that okay to everyone? किसी किसी बच्चे ने बी आंसर दिए बेटा. इट इज नॉट कॉज्ड बाय सिम्प्लेक्स, इट इज कॉज्ड बाय जोस्टर टिपिकली. चलो ये बताओ, देखते हैं इफ यू रिमेंबर दिस क्वेश्चन फ्रॉम यस्टरडे. सो व्हाट इज द आंसर हियर? मैंने कहा था कि सभी बच्चे सूडोमोनास बोलते हैं और अब सबकी पिटाई होगी, है ना? मैंने स्पेशली कल लिखा था कि सबको लगता है कि सूडोमोनास होगा. व्हाट इज द आंसर हियर? व्हाट इज द आंसर? The answer is A, Neisseria gonorrhoeae. What is the mnemonic here? Contact lens safe नहीं है. नहीं है means Neisseria gonorrhoeae. ठीक है? Everybody earlier was saying pseudomonas. If you remember from your notes, I have typically written pseudomonas is not one of those. Do you remember? Do you remember? आज सबकी पिटाई होगी, ऐसा है? याद आया सबको कि नहीं? डॉक्टर साहू, चलो ठीक है. चलिए, let's read this question. It's a very nice question. Try to identify first of all this ulcer. What do you think this ulcer is? कैसा लग रहा है आपको ये अल्सर क्या है? It's a fungal ulcer, isn't it? This is typical feathery margins. देख रहे हो? Typical feathery margins. Very good. है ना? Now tell me the answer. Thinking about that this is a case of fungal ulcer. What should be the answer? Very good. Now it's right. F. Fungal fixed feathery. Fungal fixed feathery. Very good. So ring ulcer is there, but it is not characteristic because it can be seen in a pseudomonal ulcer and a xanthamoeba ulcer also. ठीक है, वेरी गुड वेरी गुड. ये बताइए, इट्स अगेन अ वेरी इंपॉर्टेंट वन गाइस, इंपॉर्टेंट क्वेश्चन. Why cornybacterium diphtheria, doctor? Why a is a hyphae? So you have to have a fungal ulcer, isn't it? What is a fungus here? Fusarium. Microbiome में पढ़ा है ना, different funguses. So fusarium is a kind of a fungus. Now let's solve the question. There is a typical history of trauma by a vegetative material. This is the most important clue. Vegetative. Then you have feathery, you have hyphae, you have satellites. What else do you want? You have here so many clues, guys, and the answer is fusarium. ठीक है, convinced everyone? चलो ये बताओ, again an important one. What is the most appropriate adjunctive drug for treatment of fungal ulcer? Very nice, guys. Dr. Priyam. Why it is not nystatin? It says what is the most appropriate drug? Adjunctive drug. Adjunctive matlab that you are already giving a natamycin. You are already giving a natamycin. What else do you want to give? So I told you for every corneal ulcer we must give cycloplegic agent because there's a lot of pain. If you don't relieve the pain with that adjunctive drug, the ulcer will not be healed. ठीक है? आप जो कह रहे हो डॉक्टर प्रियम, वो ये कह रहे हो कि आप निस्टैटिन, आप नाटामाइसिन दे चुके हो, अब क्या करोगे? पहले ये तो होने दो कि नाटामाइसिन से काम नहीं बना. If natamycin is not working efficiently along with atropine, then you can start with nystatin. ठीक है? Again, it's an expected question this year, guys. So what is happening here? Read the question well. So parotid tumor की सर्जरी के बाद क्या हो सकता है? What is the relation of this parotid tumor surgery here? ENT में हुआ है आपका बेटा? Very good. You can have a facial nerve injury. When you do a parotid tumor surgery, you can have a facial nerve trauma. So if your facial nerve gets damaged, you may have lag of thalamus. If you have lag of thalamus, you may have a neuroparalytic ulcer. Very, very good. ठीक है, so you have a clinical question here, guys. बन गया ना clinical question? यहाँ कहीं उन्होंने कोई और कुछ नहीं दिया है. ठीक है, very good. This one is a simple one. Immune ring is a feature of. It's a fungal corneal ulcer. What is the name of the ring? Weasley. Okay. Chalo, something from your pharma. Let's see if you know your pharmacology well. Yes. So phenylephrine does not cause cycloplegia. It's a plain mydriatic. It dilates the pupil, but it does not relaxes the ciliary muscle. Okay. Rest everyone. Rest everything has both the action. आप समझते हो ना, दो अलग अलग एक्शन है. एक डायलेटर एक्शन है which dilates the pupil, एक एक्शन है ciliary muscle को रिलैक्स करने का. There are two actions. Okay. चलो, let's start with the next topic. The next one is corneal dystrophies. The next topic is corneal dystrophies. Dystrophy of the cornea. So friends, first of all, corneal dystrophies can be classified into three types. First is the epithelial dystrophies. That means the defect is in the epithelium. There is a problem in the epithelium. The second problem is the stromal dystrophies. That means the problem is in the stroma. And the third one is the endothelial dystrophy. There are three types of dystrophies. Now, epithelial dystrophy means the problem is in the epithelium. So what is the problem? The problem is that the basement membrane. The problem is that the basement membrane of the epithelium, the basement membrane of the epithelium is unstable. Do you remember the basement membrane of epithelium, guys? आपको याद है कॉर्निया में एक एपिथेलियम के अंदर कई सारी लेयर्स थे? डू यू रिमेम्बर? है ना? No, not Bowman's layer, just above the Bowman's layer. So that basement membrane is unstable. So suppose, guys, that basement membrane is unstable. What would happen to the epithelium? The epithelium will get eroded on its own. Repeated erosion of the epithelium of the cornea. Okay, this is the problem. The patient will have a repeated, painful, spontaneous epithelial erosion. Spontaneous epithelial erosion. इट्स अ पेनफुल वन. अपने आप ही बार बार जो कॉर्निया की जो एपिथेलियम है वो हट जाती है because the basement membrane is not stable. Okay, so patient will have a repeated erosion of the corneal epithelium. Yes, it is not properly attached, so that is why it erodes on its own. देखो उठ के अपने आप हो रहा है. Suppose there is a small trauma and then there is a defect, that is understood. But suppose my skin epithelium is detaching on its own, then there must be some problem. Yes or no? So this is the problem. This is not congenital, but they are early in the age. Maybe in young, you can say. Okay? This is not congenital, but occurs early in the age. Now the next thing which you have to learn is the name. What is the name? The name is map dot, map dot, or fingerprint, map dot, or fingerprint, or Cogan microcystic dystrophy. Cogan microcystic dystrophy. ठीक है? So three names here: Cogan microcystic, या fingerprint, या map dot. ठीक है? All three of them are same. Now stromal dystrophies को याद करने के लिए we have a very simple mnemonic. To learn stromal dystrophies, we have a very simple mnemonic, which is Marilyn Monroe got hurt in Los Angeles. So पहले समझ लीजिए, फिर I'll give you time to write. So there are three types of stromal dystrophies where something abnormal gets accumulated in the stroma of the cornea. ठीक है? It can be mucopolysaccharides, it can be hyaline material, or even it can be a amyloid material. So very simple. The three dystrophies are Marilyn Monroe got hurt in Los Angeles. मतलब in macular dystrophy, mucopolysaccharides are accumulated. In granular dystrophy, hyaline material is accumulated. In lattice dystrophy, amyloid is accumulated. ठीक है? बहुत ही simple mnemonic है. You can just quickly write down. ये नहीं आपको याद करना है. You don't have to remember the stains. Forget the stains. Forget the stains. Okay? You need not to remember the stains. Now, after you finish writing this, guys, there are 3 more questions. Please remember, which is the most common one? Lattice is the most common. Which is autosomal dominantly inherited? Again, lattice. The least common, the worst prognosis and autosomal recessive inheritance is for the macula. Okay? So, बहुत सारे questions हैं guys. 2017, long back, you had a question from macular dystrophy. They have already asked you. Yes, they do repeat, Dr. Shubham. See, my idea of a repeat question is that the topics are definitely repeated. है ना? So if they have given you a question on dendritic ulcer, they may not ask you the very same question, but they can give you from the same topic. Earlier they have given you the picture, now they can give you a clinical question, or they can give you what is the treatment. So I say this is also the repeat question. ठीक है, Dr. Shubham? Dr. Aishwarya, worst prognosis is macular. Yeah. Granular is nothing. You don't need to remember even granular. You remember the rest of the things and then the things will be easy. So Dr. Shubham, I'm already doing that. I told you that development is not important nowadays. I told you the corneal ulcers are important. Okay? Okay, we are doing that. I'm telling you simultaneously that which topic is very important. Like anatomy of cornea, I told you is very important. Neurophthal will read tomorrow. Chalo. So after this stromal dystrophy, let's talk about endothelial dystrophy. So you just have to remember 2 things. The name is Fuchs endothelial dystrophy. Fuchs endothelial dystrophy, and it is because of loss of endothelial cells. You remember the endothelial cells are very important for transparency of the cornea. So gradually there is a decline of endothelial cells. ठीक है? Usually seen in elderly females. Elderly females. ठीक है? बहुत बूढ़ी औरतों में देखने को मिलता है elderly females. Fuchs endothelial dystrophy. Now guys, think about it yourself and you have to tell me the answer. Let's see if you have understood something or not. Suppose there is a patient of lattice corneal dystrophy. He's just 30 years of age. Obviously, something is deposited in the cornea, so that cornea will become opaque. Cornea will lose its transparency. So this guy needs a transplantation of the cornea. You have to replace the cornea. So which type of keratoplasty would you like to do? A penetrating or a lamellar? Understood my question? Yes, I may do a lamellar because the problem is in the stroma. So I can divide the cornea like a layer of duas and then I can give only the interior part of the cornea. Okay? Is it clear? Elderly females. Elderly females. Chalo. So after this topic, ये बताइए. Let's see if you can answer the question. Fuchs. Dr. Gotham, why do you say D? Why do you say D? There's a young boy. There's a young boy. There's the young boy who comes to you with recurrent erosion. So it has to be a Cogan-Maprein dystrophy. All right, guys. See, every problem in young boys is not that. Now you have to read the rest of the question also. Okay? Chal. The next pathology which I would say is very important is keratoconus. Okay, now let us understand first what is keratoconus. The word kera means cornea, the word conus means conical. So it is a progressive idiopathic ectatic disorder of the cornea where the cornea becomes progressively conical in shape. Can you see? Normally, if the cornea is like that, it is a progressive disorder where the cornea changes its curvature and becomes conical and even thin. Now, this kind of problem generally occurs in young girls, like who are 17, 18, or maybe 20 years of age. So, guys, at this age, 18 or 20 years of age, we consider that the power of the spectacles should get stable. But if their curvature is changing, what should happen to their power? Do you think the number would get stable, guys? Do you think the number would get stable? No. So which kind of refractive error do you expect? Yes, Dr. Imad, very good. So because of the change in the curvature of the cornea, we expect cylindrical power, we expect astigmatism to the patient, isn't it? Because the number should not be stable, the cornea is getting progressively ectatic. So they will have a astigmatism mainly. Okay guys, chalo, let's write down certain theoretical points. Okay, so the word keratoconus means a conical cornea. What do you mean? It is a conical cornea, simple conical cornea. Okay, so what exactly it is? It is a progressive idiopathic ectasia of the cornea which is associated with thinning. It will lead to a thinning of the cornea also. Cornea will get thinned also progressively. Okay? Now, what is the clinical feature? So the clinical features are that it generally affects young girls, usually in their second decade. Usually in their second decade. So what is the problem? The problem is when your cornea is unstable, they come to you with repeated change of spectacle number. After every few months, they'll come to you and they'll say, Doctor, I can't see clearly. Probably my power is again changed. My power is again changing. After every 4 to 6 months, they'll come to you. Okay? Repeated change of the glass number. Why? Why is this happening? Because of introduced astigmatism. क्यों हो रहा है ये? क्योंकि पेशेंट को एस्टिग्मेटिज्म हो रहा है. ठीक है? You can also have a myopia, but mainly it is astigmatism. See, Dr. Ishwarya, contact lenses generally are used to treat keratoconus, a different type of contact lenses. But definitely, if you put contact lenses for a longer period of time, they can also change the curvature of the cornea. They definitely do not cause a keratoconus, but they change a little curvature of the cornea. Okay, you don't call it keratoconus. This can also occur in males. Yes, why not? But more commonly seen with females. Trauma has no relationship. It is an idiopathic disorder. Trauma has no relationship, beta. But definitely it can be seen in young males also. Okay? Now, so the problem is this repeated change of glass number. Now, when I see these patients, I see so many signs. The first sign, the very, very important question is on Munson sign. 2020, you had a picture question on that, Munson sign. So I'll write down the theory first and then I'll explain few things. Munson sign is a very famous sign, though it comes late, but it is actually a notching of the lower lid when you look down. Notching of lower lid on looking down. Okay, so very favorite question, very commonly asked question of examiners. Notching of the lower lid when you look down. The next one is the prominence of the corneal nerve. The corneal nerves becomes prominent. Corneal nerves becomes prominent. Prominence of corneal nerves. The next one is oil droplet sign. The next one is scissoring reflex. Scissoring reflex. The next one is Fleischer's ring. So each and every word is a question, friends. You have to learn each and everything here. Fleischer's ring is nothing but iron accumulation. Iron accumulation on the epithelium of the cornea. So you remember the Stocker's line? Stocker's line was also a line of iron accumulation, and this is a ring of iron accumulation. Okay. So Fleischer's ring. Next one is again important, Voigt's stripe. Voigt's stripe. And what are Voigt's stripe? Simple to remember, V and V. These are vertical stress lines on the Descemet's membrane of the cornea. Vertical stress lines on the Descemet's membrane of the cornea. The next one is acute hydrops. So guys, first of all the signs are very important. So these are the signs. Now if you need some explanation, I will tell you one by one. देखिए इसको. Please see. So this is your first sign, Munson sign. All of you please see. Normally when I look down, my lower lid is this. There's no bulge, there's no notching. But if the cornea is protruding, what will happen? The cornea will press upon the lid. So when the cornea is pressing upon the lid, there's a notch. Can you see? Bulge cornea है ना, तो ये lower lid को धक्का मारता है. So lower lid में notch बन जाती है. This sign is your Munson sign, a very classical sign. ठीक है? Now, this is an oil droplet sign. It appears as if a drop of oil is seen on water. Like because of that bulge, it gives you a certain kind of reflex. Okay? It's not a picture question. Now, normally your corneal nerves are not seen, but because there is a thinning of the cornea, the nerves becomes prominent. ये cornea की nerves आपको दिखने लग गई हैं. Otherwise, cornea की nerves दिखती नहीं है बेटा. ठीक है? Now, what is this Fleischer's ring? I told you Fleischer's ring is the ring of deposition of iron on the epithelium of the cornea. Now what about striae, the Voigt's striae? So look at me everyone. This Descemet's membrane is also a very resistant membrane like Dua's layer. So whenever there is a thinning, obviously the cornea will probably someday perforate because there's a thinning. So this Descemet's membrane tries to resist that pressure. Because it is trying to resisting that pressure, it itself is thrown into vertical folds. And these vertical folds are striations, which we call Voigt's striae. Okay? And what is this acute hydrops? This is actually one fine day there is a perforated cornea. Okay? There can be a perforation in the cornea. This is called as acute hydrops. So each of them is a question. Now, how to diagnose? So what is happening? Because my cornea is not having a normal curvature. When I see somebody's cornea through keratometry, you remember keratometry? Keratometry is something by which we measure the curvature of the cornea, है ना? Keratometry. Okay, Dr. Khanna, Dr. Achal, see, अगर आप किसी चीज को फाड़ने की कोशिश कर रहे हो तो उसमें स्ट्रेस लाइंस नहीं आएंगी. एक कपड़ा है, वो आप कपड़े को ऐसे खींचना चाह रहे हो तो क्या होगा, उसमें फोल्ड्स से नहीं आने शुरू हो जाएंगे, स्ट्रेस. सो दैट इज क्रीज यू कैन से. सो दैट काइंड ऑफ स्ट्रेस लाइंस व्हिच आर सीन जस्ट बिफोर द परफोरेशन, दिस इज कॉल्ड एज striae. ठीक है? कॉर्निया पतला हुए जा रहा है तो वो फट सकता है. सो फोल्ड्स आने लग जाते हैं डेस्मेट बिकॉज इट ट्राइज टू रेजिस्ट दैट स्ट्रेच. itself it is shown in folds. ठीक है बेटा? Now there is a very very important expected question which is depicted here. देखिए सभी लोग, this is a Placido disc test. Now very simple to understand. When I look into your eye, ठीक है? So into your cornea, my small miniature image will be formed. Yes or no? Whatever you see, the image is also shown in a very miniature form on your cornea also. Yes? So what I will do, I'll take this Placido disc which has a central aperture and has black and white concentric rings and hold this into the handle and look towards the cornea. Suppose if your curvature is normal, in your cornea I'll see concentric folds like that, concentric circles in the cornea. But suppose if your curvature is not normal, what will I appreciate? Something like this. देखिए, what is happening? Irregular Myers. Irregular. Irregular means the curvature is not normal here. Are you able to understand, guys? This is a simple test. I will see the reflection of this Placido disc into your cornea. Am I clear? So this is first of all diagnosed by Placido disc test. Please write down how to diagnose. First is Placido disc test. To check curvature. And this is a picture question. ठीक है? Placido disc is a picture question. You can draw like that Placido disc. Am I clear, guys? But Placido disc only gives you the information about the anterior cornea, that the curvature is not normal. It doesn't tell you anything else about the cornea. How thin is the cornea, how thick, where exactly is the curvature less, and nothing else about the anterior curvature. Okay, so Placido disc, I'll say it's not the best to diagnose, but it's giving you a clinical, a quick bedside clinical test. Okay, what is the best one? Best is topography of the cornea. And what is the name of the instrument, guys? You have to learn this. It is called as pentacam. Pentacam. Okay, pentacam. Irregular Meyer was from the curvature in Placido disc. In Placido disc. Okay. Now how to treat? So guys, is you keep on changing the spectacles. Every 4 to 5 months you change the spectacles. Do you think it is the best option? Just keep on changing the spectacles. No, it's not a very good option. Isn't it? It's not a very good option. आपने बीमारी को तो ठीक ही नहीं किया, आप तो सिर्फ नंबर बदल के दे रहे हो, है ना? So the another thing is that you can give contact lenses in these patients. These contact lenses are different. These contact lenses are called as rigid गैस परमिएबल कॉन्टैक्ट लेंसेज, RGP लेंसेज. ठीक है, ये जो कॉन्टैक्ट लेंस होते हैं बेटा, ये थोड़े अलग तरीके के लेंस होते हैं. जो हम रोजाना पहनते हैं ये वो नहीं होते. जो हम रोजाना पहनते हैं ये वो नहीं होते. नो गाइस, केराटोप्लास्टी इज द लास्ट रिजॉर्ट. अगर कॉर्निया फट गया है तब केराटोप्लास्टी करते हैं. ठीक है, इट इज द लास्ट रिजॉर्ट. Rigid gas permeable contact lenses have a property that if your curvature has gone this, if you keep on wearing RGP lenses, the cornea curvature will come back to the normal. Okay, but it does not stop the progress. So to stop the progress, we have another procedure which we call is C3R, corneal collagen cross linkage. Corneal collagen cross linkage with riboflavin drops. ठीक है, with riboflavin drops. So this is your treatment of choice. This is the treatment of choice because it stops the progression. It stops the progression. So this is the treatment of choice. Okay. So they ask you, riboflavin is which vitamin? Vitamin B2. So vitamin B2 is used in treatment of which pathology? It is used for treatment of keratoconus. ठीक है, इसमें क्या करते हैं बच्चे, कॉर्निया के ऊपर देखिए इसको, देखिए इसमें क्या करते हैं C3R में. So you put riboflavin drops. First of all, you put riboflavin drops, and then you put ultraviolet A light. So what is ultraviolet A light? If you show ultraviolet A light, then there will be strengthening of the cornea, and that's what we want. That cornea should get strengthened, which was getting very weak and thin. Okay. See, pentacam is a diagnostic modality for the topography. ठीक है, मैं समझाती हूँ. अच्छा डॉक्टर ऋषभ सुनो, डॉक्टर ऋषभ देखो ध्यान से सुनो. सपोज करो आज आपको एक लड़की पसंद आई है. ओके, सो यू सपोज यू लाइक सम गर्ल एंड यू वांट टू नो अबाउट हर. So you just saw her and you came to know what is her name. This is a very superficial information that you got to know the name. So the name is Placido disc. You got only anterior thing, the name only, okay? But you liked her more and you want to know more and more. You want to know everything about her. You want to know where she lives, in which class she is, what is the name of her boyfriend, and whatever. So you want to know everything about her. So this everything about her is the pentacam. Okay, topography is the pentacam. Pentacam is the name of the topography technique. Okay, Dr. Rishabh, I hope you will not forget this for your entire life now. Pentacam and topography. Okay, so you can. Why do you say it's a irreversible disease? I told you, you can stop the progression. You can stop the progression. You stop the progression. You make the strengthen. You make the cornea strengthen, and then you can put the contact lenses. So your cornea will be shaped back. You have stopped the progression. Okay. Okay, it's not an irreversible disease. Pentacam, it's a machine, beta. It's a big machine. उसमें scan लेते हैं हम लोग. Cornea के scans लेते हैं. This is your pentacam image. This red and blue image is your pentacam image. Okay, it's an instrument. Yes, it's a big machine. चलो इस क्वेश्चन का आंसर बताएं सभी लोग. Think about this question and answer. Okay, let's try to solve it. Munson sign is seen in keratoconus, cave ring is with Wilson, satellite disease ulcers are with fungus, geographic is with herpes. ठीक है? So this is the answer, guys. Okay? चलो, ये बताइए. Rishabh would like to answer this question. ठीक है? Dr. Rishabh is gonna answer for that. So we are waiting for you, Dr. Rishabh. What is the test? Is it pentacam? अभी pentacam में दिखाई नहीं, रेड ग्रीन कलर की पिक्चर है. A is the answer. Why do you say it's a keratoconic cornea? Do you see the normal Myers? क्या बात करते हो बच्चे? ये नॉर्मल नहीं दिख रहा है आपको? Don't you think it is the normal curvature of the cornea? Yes or no? It's a Placido disc test, so it's a normal cornea. Okay. Why do you think if it has to be a keratoconic cornea, you will see this kind of Myers, abnormal Myers. Okay. Okay, friends, clear? Why the answer is A? Everyone? Any problem? All of you? These Myers are normal Myers. This is what you see in me, I see in you if you do not have a keratoconus. ठीक है, ये normal है बच्चे. चलो ये बताइए. A very intelligent question. Let's see if you can answer. ये कौन सी बीमारी है पहले तो ये बताओ. Which बीमारी is this? Which pathology is this? Very good. So we have a Munson sign here, isn't it? So I've given you a ulta question. I've given you Munson sign. You must find out the bimari pehle. You must find out the pathology first. So you know it is keratoconus and it's never seen in middle-aged males. It's seen in young people, younger people. ओके गुड. ये बताइए, व्हाट अबाउट दिस गाइस, व्हाट आर स्ट्राइवोक स्ट्राइव? क्या तुम भी एक बोलता है तो सब बोलने लग जाते हो, है ना? Vogue striae are vertical stress lines in the Descemet's membrane of the cornea. ठीक है, चलो good. So the last topic in cornea which we are going to read now is something about the refractive surgery, the LASIK. So what is LASIK guys? अच्छा ये बता दो फिर से, ऋषभ बताएगा क्या है सिंपल वाला? ऋषभ बताएगा बच्चे, सिंपल क्वेश्चन. Yes. This is not topography. This is only for the interior curvature. Okay. What is the name of the instrument? Placido disc. It's an expected question. Chalo, let's talk about LASIK. So first of all, what is LASIK? LASIK is a cosmetic procedure by which one can get rid of the glasses. Okay, one can get rid of the glasses. Most commonly, we use LASIK for treatment of myopia. Because if somebody hates the glasses or somebody doesn't want to use glasses, we can do a cosmetic surgery in him. Now, the basic idea in LASIK is that we decrease the thickness of the stroma of the cornea. Okay? So what was the normal thickness of the stroma, the central thickness? It was approximately 520. You remember? The central corneal thickness was approximately 520. So we reduce the thickness of the corneal stroma depending upon the number of the chashma, number of the glasses. Okay? Now suppose somebody has a power of -1 diopter, -1 diopter. किसी के पास चश्मा है जो -1 का चश्मा पहनता है, तो मैं उसकी स्ट्रोमा में से अप्रोक्सीमेटली 15 माइक्रॉन्स थिन कर दूंगी. What will I do? What will I do? For correction of -1 diopter myopia, stromal thinning of approximately 15 microns is required. Are you able to understand? मुझे बेसिकली स्ट्रोमा को पतला करना है, डिपेंडिंग अपॉन मुझे कितना ठीक करना है. अगर किसी का चश्मे का नंबर -3 है, एग्जाम्पल, if somebody has a power of -3, how much stroma should be thinned out? Approximately 45 microns. Am I clear? ठीक है, बेसिक आइडिया क्या है? स्ट्रोमा को पतला करना है. नाउ हाउ डू वी डू दैट? The thing is that we use a laser and the name of the laser is excimer laser. What is the name of the laser? By use of excimer laser, we do actually the thinning of the stroma. Okay, this is the main idea. And we call this process to be photoablation. So this is the second type of laser we are using. First we used in cataract, ND glass, ND Young. Next one is photoablation, where we are doing the thinning of the corneal stroma by the use of excimer laser. Okay? Now exactly in excimer laser, what gas is used? We use argon fluoride gas. And what is the wavelength? 193 nanometers. This is the wavelength. 193 nanometers. Okay? 193 nanometers is the wavelength. Okay guys? Now, I told you myopia is the most common indication. But we can do this in hypermetropes and astigmatism also. Myopia is the most common indication. Okay? It's a cosmetic procedure. It is not a treatment. It is actually a cosmetic procedure to get rid of glasses. Now, how exactly we are doing that? Let's come back to the photo and try to understand. Please see first. I'll give you time to write. Okay, देखिए पहले. So what are we doing here? Please see. First of all, this is my cornea, all the layers. I lift the flap of the cornea, which is composed of epithelium and superficial stroma. I lift the flap. ठीक है? This is a hinge flap. Now what is left here? The remaining part of the stroma. Now I'll press a button, the laser light will come, it will do the stromal thinning on its own, it will disappear on its own, and then as a surgeon I'll put back the flap and say tata bye bye. Simple. ठीक है, पहले हमने एक फ्लैप बनाया, लेजर डाला और फ्लैप को बंद कर दिया. ठीक है. So it's very simple. It's like 5-minute procedure for each eye, right? But is there any side effect? What about residual cells means? Yes, flap gets sealed on its own. Flap gets sealed on its own. Okay? But what are the side effects? So guys, side effects are, I would say, they are so many. Theoretical, they are so many, but practically they are not so much. Okay? So guys, when you are making this flap, which is a epithelial hinge flap, this is your whole flap. So you're making an incision, isn't it? You're making a big incision which is like this much. You're making a big incision. When you make such a big incision, you induce dry eye. You induce a lot of dry eye. Why? Because you damage lot of corneal nerve endings. Okay? Damage lot of corneal nerve endings. So theoretically, definitely we have lot of side effects. Practically also you see that the patients have lot of dry eye after the LASIK. And there can be so many flap related complications. Why? Because once you are creating a flap, you do it by a machine. So when you make a flap, you make flap related complications. You need not to go into detail, but yes, there can be flap related complications. Okay, so there are certain side effects. Now, are there any contraindications of LASIK? Anything, anywhere where we cannot do LASIK? So the first is when your age is less than 18 years, you cannot perform the LASIK. Second, if you have an unstable power. If you have an unstable power for last 6 months, you should not do a LASIK. Why? Because the number is not stable. क्या आप ठीक करोगे? जब number is stable नहीं है, तो क्या ठीक करोगे? है ना? The next is if the central corneal thickness is less than 450. That means if the cornea is already thin, you should not do further thinning. पहले से ही cornea पतला है और आप और पतला कर दोगे तो क्या होगा? Perforate हो जाएगा. Next, very important is keratoconus. Obviously, for the same reason that the number is unstable and cornea is thin. The next one, as she said rightly, is pregnancy and lactation. The same thing, the number gets unstable in pregnancy, lactation. That is why you should never do a LASIK here. Okay? So this is the latest in cosmetic surgery for myopia, smile. Now guys, in LASIK, you were making a big incision, isn't it? You are lifting a flap. So this was the thing which causes a problem. But no guys, Dr. Saini, there's hardly any side effect practically. I kept on saying that. So nowadays, what we are doing, a very sophisticated surgery where we are just making a small smile shape incision, very small. And you are doing stromal thinning by a different method. So what is this method? Please see all of you. Suppose can you see in LASIK we have raised a flap. This is your flap. So there can be so many complications, theoretical complications. Hai na? You're making a big incision which is like 20 millimeters. But in relic smile, what we are doing? We are making a very small incision, a very, very small incision, 2 millimeter incision, and we press the laser button, and this laser will create an area of a lenticule within the stroma, which is required to be taken out. LASIK में हमने बटन दबा के स्ट्रोमा को थिन किया था. स्माइल में हमने बटन दबा के अंदर ही अंदर कॉर्निया के एक छोटा सा लेंटिक्यूल प्रिपेयर कर लिया, जिसको बाद में हम फॉर्सेप्स से पकड़ के खींच के निकाल देंगे. Are you able to understand? We are not showing direct laser light on the required stroma. We have created an area of the desired thickness what we want to take out. and that will be taken out through a very small incision. That is why we say lenticular extraction. Okay, small incision, lenticular extraction. Okay, is it clear, friends? What is smile? So it is actually a bladeless and a flapless technique. So that is why the side effects are less. Results wise, both of them are almost the same. Yes, it is very costly. It's like 1 lakh rupees. Plain LASIK starts from 20,000, but this is almost a lakh rupees. ठीक है बेटा? No, PRK doesn't come in smile. PRK is done only when you cannot do LASIK. Suppose the cornea is very thin where you cannot do LASIK, there you are doing PRK. Okay, friends. So this is about the refractive surgery. You should know these two. Okay. So what is this smile? It is a bladeless and a flapless technique. Okay, it's a bladeless and a flapless technique. Okay, bladeless and a flapless technique. Okay, smile. Chalo guys, before we start a new topic, anything, any problem, any question which you have, any doubt, anything which you haven't understood. All clear in cornea? So again, anatomy of cornea is very important. All the corneal ulcers, picture questions, the treatment, specific things in every ulcer, how do you treat the ulcers, and then keratoconus. I would say these are the most important topics in cornea. Very important. Myopia recurs after LASIK. Myopia, little bit can come, some sort of errors can be there in any type of surgery. Some kind of myopia, little myopia can come again, like a 0.5 or a 0.75 number, especially when you conceive or you are in a period of lactation. Mainly the hormonal changes. Okay, anything, Dr. Yogita, what do you want to ask? Astigmatism we'll discuss on Thursday in detail. Astigmatism will be discussed in detail. Okay, but briefly, astigmatism is when you have a change in the curvature of the cornea. Your rays of light are focused on the retina, but at many points, not at a single point. SE in smile. SE. SM is small. I is incision. एक्सट्रैक्शन लिखा है ना ये एक्सट्रैक्शन ओके yes why not Dr. Raghuvansh you can go for LASIK safely what is your power if your power is till 5 diopters you can go ahead pseudogerontoxone explanation is not required guys Dr. Ishwara it's not required I'll tell you still so pseudogerontoxone is a नहीं समझ में आया तो skip कर देना ठीक है it's an exudation around the limbus. It's an exudation around the limbus. This is pseudogerontoxone of VKC. Now, why we call it pseudo? Basically, you have to understand what is gerontoxone. Gerontoxone means arcus senilis. Arcus senilis is accumulation of lipids in the cornea in old age. Arcus senilis. Okay? Age-related change. It is related to the word geron. Geron means old age. So when you grow old, you have lipid accumulation in the periphery of the cornea, which is lipid accumulation. Okay? Now pseudogerontoxone looks like arcus. That is why we call it a pseudogerontoxone. Okay? Geron matlab old age. So in old age, you get lipid accumulation, which is arcus senilis. It is called as gerontoxone. In VKC, it is not of old age. It is seen in young boys, and it is accumulation of exudation. Okay? So it's exudation, but it looks like gerontoxone. That is why we call it a pseudogerontoxone. Okay? Anything else? Dr. Tripathi, it is not LASIX. इट्स लैसिक, ठीक है। चलो ओके डॉक्टर त्रिपाठी, कहाँ है त्रिपाठी जी? कोई बात नहीं, यहाँ मिस्टेक्स कर सकते हैं ना, एग्जाम में नहीं करना है हमें कोई भी मिस्टेक, यहाँ करो जितने मर्जी करो, बट एग्जाम में बी कॉन्फिडेंट, ठीक है। चलो, now let us start with a new topic. We will discuss what is glaucoma. So before we go on to a little break, we will discuss what are the basics in glaucoma. So guys, if I talk about glaucoma, what is the first thing which comes to your mind? What is the first thing which strikes your mind? What is glaucoma? So it is related something to your intraocular pressure, isn't it? Guys, now why do you have a intraocular pressure? Why do you have a pressure in the eye? Why? Why do we have a pressure in the eye? So it's because of the fluids in the eye. We have aqueous humor and vitreous humor. We have two fluids in the eye. Okay? Now, which is more important, aqueous humor or vitreous humor? Which is more important, aqueous or vitreous? So aqueous humor is more important, though the volume of vitreous is more, है ना? But still aqueous humor is more important because this is a dynamic component. Dynamic. It is continuously being secreted, it is continuously being drained. ठीक है, समझ में आ गया? Vitreous volume is fixed since birth. Okay, so it is the dynamic component which determines the IOP mainly. Now, you should know first of all the basics. The secretion of aqueous is by what? Secretion of aqueous humor is by what? It is by the pars plicata of the ciliary body. Do you remember? Pars plicata of the ciliary body. कल हमने याद किया था, है ना? So aqueous is secreted by the pars plicata of the ciliary body. Now after this we should know about the drainage also. Drainage is very important, something very basic. तो ये aqueous humor drain कैसे होता है ये समझने के लिए we will see a picture. Okay, see here all of you. Please pay attention on the left side of this figure. The left side, ठीक है? This is the left side of the figure. Please pay attention. Let us see this. Now this is the region where your aqueous humor is secreted, isn't it? यहाँ से, ठीक है ना? Aqueous humor बना तो कौन से चैम्बर में चला गया? Which chamber is this? Which chamber is this, guys? So this is your posterior chamber. Posterior chamber. Dr. Madhvi, it is not anterior chamber, beta, it is posterior chamber. है ना? Now this is your pupil. So from the pupil, it is coming into your anterior chamber. Now this is the anterior chamber. Yes or no? ठीक है? So from the posterior chamber through the pupil, it goes to your anterior chamber. Again, from the posterior chamber, it goes to the anterior chamber. Now when it comes to the anterior chamber, it encounters an angle. It encounters an angle, and this is the angle. Can you see the angle between cornea and the iris? Now within the angle, it passes through 5 structures. One of the most important structure is the trabecular meshwork. ठीक है? अब ये trabecular meshwork छन्नी की तरह होता है. It's like sieve. So aqueous goes through the sieves by resistance and then finally gets absorbed by the episcleral veins. Okay? This method is the most important method of drainage. That is why we call this method of drainage to be the trabecular drainage. ठीक है? So we were talking about the drainage. We have 2 types of drainage. The first one is a trabecular drainage. Please write down trabecular drainage or trabecular outflow. This drainage is the most important outflow because more than 90% of the drainage occurs through it. Is it clear to everyone? Why do we call it trabecular? Because trabecular meshwork is the important part within the angle. ठीक है? The most important part of the angle is trabecular meshwork. That is why we call it trabecular drainage. Is it clear to everyone? Friends, is it clear to everyone? What is this trabecular drainage? किसी को नहीं समझ में आए तो पूछ लो. This is very basic. MI is most important drainage because 90% of drainage occurs through it. Most important. Yes. Don't be sorry, Dr. Sahu, please. Relax. I'm coming back to the diagram. Let's talk about the drainage again once more. Okay, once more. So I am telling you that this is the site from where your aqueous is produced. This one. From that it comes into the posterior chamber. Through the pupil it comes into the anterior chamber. If you remember what was anterior chamber and what is posterior chamber. Now when it comes to the anterior chamber, it comes in the angle. What is this angle? Angle between cornea and iris. When it comes into the angle has 5 important structures. One of the structure is trabecular meshwork. Now it comes out and finally it gets absorbed by the episcleral veins. We call it the conventional outflow, the most important outflow, because almost 90% of the drainage occurs through it. Now is it clear to everyone? Yes, Dr. Sahu? Clear hai bache? Chalo. Now, what is the second outflow? Second outflow is UVO. ध्यान से समझो. Nothing to be written here. UVO scleral. I hope you remember the word uvea. Uvea was iris, ciliary body, and choroid, and sclera means sclera. So it starts from the uvea, comes in the posterior chamber. Through the pupil, it comes into the anterior chamber. But instead of going through the trabecular meshwork, through the angle, it comes back towards the sclera. Can you see? This is अभी तो repeat किया बेटा मैंने. Dr. Mayank, I had just repeated for Dr. Sahu. Did you understand? No. So this was the uveoscleral outflow. The word uvea means iris, ciliary body, and choroid. So it goes through the uvea, but it does not passes through the angle. Instead, it moves behind towards the sclera. पीछे की तरफ वापस आ जाता है स्क्लेरा की तरफ, इसीलिए क्या नाम दिया है? यूवियोस्क्लेरल आउटफ्लो. हाँ जी, नाउ टेल मी, ओके और नॉट? सबको क्लियर है कि नहीं? So this is your uveoscleral outflow. Uveoscleral, blue wala, uveoscleral. What is this trabecular meshwork wala? Trabecular meshwork wala is this, through the trabecular meshwork. Okay? कौन सा स्पेस बेटा? शुभम, कौन सा स्पेस बच्चे? Which space are you talking about? Dr. Mayank, is it okay? Uveoscleral. हाँ, it goes through the ciliary body itself. Yes, but it comes into the angle first and then it goes back towards the sclera. Okay, so this is about the drainage. Now let's talk about the angle. So this angle of anterior chamber. Yes, so this angle of anterior chamber, guys, it's it is the angle which is in between cornea and iris. It is the angle which is in between the cornea and the iris. Okay, cornea and the iris. Now to see this angle between the cornea and the iris, we have to do a investigation, and to see this we do a gonioscopy. Okay, so this is a very important question. When you want to see the angle of anterior chamber, it is seen by an instrument which is called as gonioscope. Okay, gonioscope. Now have a look here. Now, a picture question. What is this instrument? So this instrument, the bulky one, this one is your slit lamp. ये slit lamp है, ठीक है? This is your slit lamp. This is your doctor, the patient, and this is your gonioscope. Okay, you can see the angle of the anterior chamber with the help of the gonioscope. So this technique by which we can study the angle is called as gonioscopy. ठीक है भाई, what is gonioscopy? I hope you have understood. Now please see everyone. This is very very basic, बहुत ही basic चीज है. मैंने कहा था कि angle में 5 structures हैं. One important structure is trabecular meshwork. Do you remember? You need not to learn what are the different names. You need not to learn, but only understand that trabecular meshwork is one such structure, and each structure is represented by an individual line on gonioscope. जब आप गोनियोस्कोप करते हो, आप देखते हो, तो नॉर्मली हमें कुछ लाइंस दिखाई देती है. कैन यू सी दिस? द ब्राउन बैंड, द वाइट बैंड, द ब्राउन बैंड, द वाइट बैंड. देयर आर सो मेनी बैंड्स हियर. कैन यू सी मैग्निफाइड व्यू? है ना? Similarly, in this picture, you can see multiple lines. The dark band, the white band, the dark band, the white band, again the dark band. है ना? So each line represents a structure in the angle. Okay. Now, have you heard about the term open angle, closed angle? What do you mean by the angle closure? Angle closure means that on gonioscopy you can't see any line. Okay, this is your closed angle. You can't see the lines. But when you see multiple lines, you say the angle is open. Okay? It is a gonioscopic classification. You say angle is open, you say angle is closed. Normally, all of the angles are open. Normally, all of the angles are open. Is it clear to everyone? What is gonioscopy? ये सब बता पाएंगे? So please write down for gonioscopy that gonioscopy is the only investigation. It is the only investigation which is done in a small pupil. When you have a small pupil, then only you can do gonioscopy. Never done in a large pupil. It's always done in a small pupil. Okay, please remember this. It's always done in a small pupil. Closed angle means that you do a gonioscopy and you cannot see any line. You can't see any structure which is in between cornea and iris. The angle is in between the cornea and iris, right? So in total you have 5 structures and each structure is represented by a line. अगर आपको सारी लाइंस दिखती हैं या ज्यादातर लाइंस दिखती हैं, दैट मीन्स एंगल खुला है. मेरा एंगल खुला है, आपका भी खुला है. बट एंगल क्लोज हो गया है, मतलब गोनियोस्कोपी पे आपको कोई लाइन नहीं दिख रही है. ठीक है प्रांजल? ठीक है प्रांजल? Closed angle देखो, closed angle is something like that. Your angle is closed. Angle is closed. See how here the angle is open. Can you see the angle is open here? The angle is full open here. है ना? Angle is open here. And see, look again, this angle is closed. ठीक है? चलो. Now let's talk about the next thing. What is this IOP? What is the normal value of IOP? Normal value of IOP is approximately 10 to 21 millimeters of mercury. ठीक है? Different book mentioned differently, but let us remember this one, 10 to 21 millimeters of mercury. Now guys, what is the name of the instrument which measures the IOP? We call it tonometer. So this measures the IOP. ठीक है? It measures the IOP. Now there are so many types of IOP guys, but at least you have to remember few. The first tonometer is indentation tonometer. The name of the instrument is Schiot's tonometer, and this is a picture question. Schiot's tonometer, very good. Dr. Priyam, very good. This is the first tonometer, Schiot's tonometer. Schiot's. ठीक है, अब इसको देखेंगे. We'll try to understand what is happening here. We'll try to understand. Schiot's tonometer. Indentation, Schiot's. चलिए देखिए इसको बच्चे. So this is the first picture here. What do you see? The patient is lying down and the doctor is pushing something on the cornea. It's putting something on the cornea, and depending upon the IOP in the patient's eye, there will be a deflection of the needle here like that. Can you feel? See? देख रहे हैं आप क्या हो रहा है? So this is the needle which moves depending upon the level of IOP in the patient's eye. ठीक है? Now, this gives you a reading, but do you think it's a good tonometer? No, absolutely not. This Schiot's tonometer has so many sources of errors. ठीक है? This Schiot's tonometer is not a very good tonometer. It has so many sources of errors. Not a good tonometer. ठीक है? There are so many sources of errors. So many source of errors, not a good tonometer. It gives you a very crude reading. ठीक है, ये बहुत कम जगह होता है जिसमें होता है ना. अब आप जाओगे तो देखोगे कि भारत देश के जो मेडिकल कॉलेजेस हैं उनकी क्या हालत है, और वहां पे ये टोनोमीटर मिलेगा ऑफ्था डिपार्टमेंट में आपको. ठीक है, और कहीं नहीं मिलता शायद से. चलो, now after that the second tonometer which we use, even which I also use, it's there in my clinic. It is your Goldman applanation tonometer. So this one is again your picture question. It is again your picture question. ठीक है, अब देखिए क्या हो रहा है. This is the small appliance. Can you see? This one is a small tonometer which is attached to the slit lamp. ये छोटा सा tonometer होता है. मेरी क्लिनिक में भी है, मैं आपको बाद में दिखा दूंगी. If we can move on the camera and everything, I'll show you few instruments from the clinic. Slit lamp, ophthalmoscopes, retinoscope. I'll show you everything. ठीक है. So ये एक छोटा सा टोनोमीटर है इतना सा, एंड इट हैज गॉट अ प्रिज्म अटैच्ड टू इट. ये छोटा सा प्रिज्म है. ठीक है, अब क्या करते हैं आप देखिए. सो we'll first of all anesthetize the patient's cornea. This is the proparacaine drops we use. Proparacaine drops, it is the anesthetic drop. ठीक है, you put the drop patient's cornea. And you turn on the blue light. Can you see the blue light here? Blue. This is the light of the slit lamp, the blue filter. Now, when you will touch some part of the cornea through the prism, you will actually see something like that. Please see. जब इतना part आपने cornea का touch किया, तो a green circle will be seen, which will be broken into two semicircles like that. ठीक है? Two semicircles. Now, there is a knob which is present on the tonometer. Tonometer के अंदर ऐसे छोटा सा एक knob है, देख रहे हो आप ये? This is the knob. And this knob has markings like that. इसमें markings है. So you'll keep on rotating the knob slowly till the point you see the end point. जब आपको ये दिख जाएगा patient की cornea पे, the moment you see this point on the patient's cornea, what is this point? It shows the inner Myers are touching each other. Can you see? The inner Myers are touching each other, something like that. Inner Myers are touching each other. So this is the end point. The moment you see this, you stop, and then you note down the reading. What is the reading? This is 10, this is 12, this is 14, this is 20. So now my reading is 14 millimeters of mercury. Am I a little clear to all of you? थोड़ा थोड़ा समझ में आ रहा है क्या हो रहा है? So what can be the questions? What can be the question? First of all, you have to identify what is this tonometer. This is your Goldman applanation tonometer. Please write down. The second type of tonometers are applanation tonometers. Applanation. The next type of tonometers are applanation tonometers. Applanation. And what is the prototype here? What is the prototype here? The prototype is this Goldman applanation tonometer. Goldman applanation tonometer. ठीक है friends, this is the prototype. Why I am saying prototype? Because this is the gold standard. This is the best available tonometer. Gold standard. ठीक है? Very simple to remember with the word gold and gold. Gold and gold. Goldman is the gold standard. You can remember that. ठीक है? Goldman is the gold standard. ठीक है? And what is the end point? You have to remember that as well. You have to remember that as well. What is the end point? When your inner Myers are touching each other. ठीक है? This is the end point. inner wires are touching each other. What is this 4422? अच्छा कोई बात नहीं, ठीक है. This is your end point. This can be a separate picture question. End point. Now guys, Goldman applanation tonometer is actually based on a law. What is the name of the law? This law is Imbert-Fick law. Imbert-Fick law. You must have remembered in physics, we have read pressure is equal to force upon area. This is what we have learned in our 11th standard. Pressure is equal to force upon area. So if you want to know the pressure in the eye, I want to know the pressure inside the eye. What should I do now? So what should I now do now? I should press a certain area by a certain force. When I press certain area by certain force, I'll get to know the pressure in the eye. Okay, so this is the law which we use here. Pressure is equal to force upon area. Though this is the gold standard tonometer, but there are certain problems with this. What are the problems? First of all, you need a clear cornea. If your cornea is not clear, then you will not be able to see anything on cornea. अगर cornea में opacity है, तो क्या आपको cornea में ये मायर दिखेगी? नहीं दिखेगी, है ना? What else? You require a slit lamp. Patient should be in sitting position. पेशेंट बैठा होना चाहिए. अगर पेशेंट लेटा हुआ है, सो रहा है, आईसीयू के अंदर है, यू कैन नॉट टेक द रीडिंग. इफ द पेशेंट इज सिटिंग, नॉट सिटिंग, और ही इज नॉट एम्बुलेटरी, he is a small child who is not cooperative, or who is like, you know, somebody bedridden in the ICU, you cannot take the reading. Yes or no? So these are the problems with Goldman applanation tonometer. For that, we have made one more tonometer which is very, you know, user friendly. It is like a pen. It is like a pen. It is tono pen. Okay, it is tono pen. It's like a pen. It gives you fairly good amount of reading in scarred corneas also. In scarred corneas also, it gives you a fairly good amount of reading. Okay, so tono pen is important. Now, what about Perkins tonometer? What about Perkins tonometer? So, Perkins tonometer is a handheld Goldman. It's a handheld Goldman tonometer. जो बता रहे हैं ना डॉक्टर इमाद, yes, it is a handheld Goldman tonometer. ठीक है, specifically used for children. It's very good for taking readings in children. All of them are questions. So if I ask you which tonometer will be useful for children, Schiot's, Goldman, Tonopen, Perkin, the answer should be Perkin. If I ask you which tonometer gives you the best reading, then say Goldman. If I ask you which tonometer gives you a reading in scarred cornea, then say Tonopen. Okay? So there are so many questions, but please realize that we have 20 more tonometers. I'm not going to tell you all the details of that part, but yes, at least this much you should remember. At least this much. Okay, friends? So friends, glaucoma, you were right in saying that the triad is when you have a high IOP. You were right. You said that high IOP leads to glaucoma, but actually this high IOP is not only glaucoma. It is actually a triad. What is triad? When you have a high IOP, your optic nerve gets damaged. Your optic nerve is damaged, and simultaneously you have defects in the visual fields. Your visual field defects are also seen. So this is a complete triad. For somebody to have glaucoma, you should have at least two abnormal findings. Either your IOP is raised, or your optic nerve damaged, or any two things should be there to classify whether this patient has glaucoma or not. Okay, there is a simultaneous damage to the optic nerve and the problems in the vision. Okay, that we'll read. But I want to say from this classical triad, there are two variations. Very important question. There are two variations. The first variation is ocular hypertension. Ocular hypertension. Now, what do you understand by the word hypertension? Hypertension is that when your pressure is high, but your optic nerve is normal, your visual fields are also normal. ठीक है? ऑक्यूलर हाइपरटेंशन मैं कह रही हूँ कि नॉर्मली ग्लाकोमा में तीन चीजें हैं. प्रेशर बढ़ता है, ऑप्टिक नर्व डैमेज हुई, विजन में प्रॉब्लम हुई. इन तीनों में से कुछ वेरिएशंस भी हैं. तो पहला वेरिएशन है कि प्रेशर बढ़ गया है बट नर्व भी नॉर्मल है और फील्ड भी नॉर्मल है. तो इसको हमने ग्लाकोमा नहीं कहा है. ठीक है, हमने इसको ग्लाकोमा नहीं कहा है. The second one is NTG. What is NTG? Normal tension glaucoma. Normal tension glaucoma means that the IOP is normal, tension is normal, but still glaucoma. तो क्या है? विजुअल फील्ड भी डैमेज्ड है और ऑप्टिक नर्व भी डैमेज्ड है. Though the pressure is normal, but still your optic nerve is damaged, your visual field is also damaged. ठीक है? It may take years for optic nerve damage. It may be a chronic change or it may be acute change also. We will read. Okay friends, so see, these are two variations and both of them are questions. What do you understand by normal tension? Suppose the pressure is normal for me. Suppose there is somebody whose pressure is 18 millimeters of mercury. It may be normal for me, but it is not normal for somebody who has a NTG. In the presence of normal pressure, he is getting optic nerve damage. He is also getting visual field damage. Am I clear now? ये सबको समझ में आता है? Now let us see guys what actually happens in glaucoma. Please see all of you. Open angle glaucoma guys, it's a chronic change. It's a chronic change which takes many years to develop. So normal vision means when you have a broad binocular vision. This is your normal field of vision. But what happens in glaucoma? See, in the last stage, what has happened to the visual field? The visual field is shrinking and you're just remaining with a central vision. देख रहे हो आप? So though your central vision remains persisting, but your field is compromised. Okay, so this actually happens in glaucoma. This kind of visual field effect we are having. Okay, now we understand what is glaucoma. Let us try to classify it. Let us try to classify it. Okay, we know that glaucoma can occur by two mechanisms. Either basically you have a high IOP, which can be because of two mechanisms. The first can be when you have an increased production of aqueous. Yes or no? Your aqueous humor is produced in a higher amount, है ना? Which is very very rare. It is seen only in one case, epidemic dropsy. Have you done in TSM what is epidemic dropsy? Epidemic dropsy पढ़ा होगा, है ना? The more common mechanism is decreased drainage of aqueous. ठीक है, IOP कैसे बढ़ सकता है? या तो aqueous ज्यादा प्रोड्यूस हो रहा है या फिर ड्रेन कम हो रहा है. अब ड्रेन कम होना is the most common. ठीक है? Now decreased drainage again can be classified into three mechanisms. First is the open angle mechanism. Open angle mechanism. The next is the closed angle mechanism. And the next one is congenital glaucoma. So there are three mechanisms by which your aqueous is draining in a lesser amount. ठीक है? This is a broad classification. या तो भाई प्रोडक्शन ही ज्यादा हो रही है या ड्रेनेज कम हो रही है. ड्रेनेज क्यों कम हो रही है? एंगल खुला है तब भी ड्रेनेज कम हो रही है, एंगल ही बंद है तब तो होगी ही कम. या फिर congenital glaucoma. ठीक है? Now we will be reading in detail. First of all, what is the open angle glaucoma? What is the open angle glaucoma? Now guys, the word open angle glaucoma first of all means the angle is open on gonioscopy. It's a gonioscopic definition. Now भाई आप मुझे बताओ, एंगल खुला है तो ड्रेनेज कम क्यों है? जब एंगल खुला है तो ड्रेनेज कम नहीं होनी चाहिए. सो व्हाट इज द रीजन? Now, open angle glaucoma, guys, will be further classified into a primary and a secondary. ठीक है? What is this primary? A primary open angle glaucoma. A primary open angle glaucoma. It's a old age related sclerosis of the angle structure, sclerosis of the trabecular meshwork. Sclerosis of the trabecular meshwork. I'll explain you, just finish writing. It is an age-related sclerosis of the trabecular meshwork. So, मैं कह रही हूँ कि primary is a age-related change. So when you are very old, है ना, when you are very old, there are age-related changes. So these age-related changes happen in the trabecular meshwork of the angle also in a certain individual. ठीक है? Now suppose this is the trabecular meshwork of my eye. ठीक है? I'm not so old. So this is the trabecular meshwork of my eye, which has sufficiently good size of the pores. But when somebody gets old, what happens? There is a age-related shrinkage of the pores microscopically. Though the angle is open, angle तो खुला है, but जो उसके अंदर छन्नी के छेद हैं, वो छेद बड़े छोटे हो गए हैं. So to make you understand, I'll just tell you some very simple thing. Suppose today you are in kitchen and your mother has asked you to drain the milk and keep it for boiling. She has gone to her kitty party और मम्मी बोल के गई है कि दूध छान के उबालने को रख देना आज. और वहां पे आपकी छन्नी पड़ी है जिसके छेद बड़े छोटे छोटे हैं. तो छन्नी के छेद छोटे हैं तो आपको ज्यादा टाइम लगेगा दूध छानने में या फिर कम टाइम फटाफट छन जाएगा? Will you take more time to drain the milk or will it be drained very simply, very quickly? It will take more time, yes or no? Because the pore size is reduced. Understood the fact? So this thing happens in old people. There's a chronic, very gradual rise of IOP. ठीक है? It's a very chronic, gradual rise of IOP. धीरे 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 IOP बढ़ रहा है. Okay? It's a very gradual rise of IOP. Though the angle is open, but still the speed of drainage of aqueous humor is gradually slowed down. Are you able to understand, guys? What is this primary OAG? हाँ जी, ओके, क्लियर टू एवरीवन? क्लियर है ना? बिल्कुल. चलो अब देखो सेकेंडरी में क्या होता है. व्हाट इज सेकेंडरी ओएजी? व्हाट इज सेकेंडरी ओएजी? Now again, suppose this is the trabecular meshwork of somebody who is like a young male. Suppose now he has a trauma. He has a trauma and he developed the blood in anterior chamber. Blood. So these blood cells can go to the angle and can get deposited, yes or no? Blood cells, you know, blood cells. So blood cells are accumulated in the angle. So what will happen? Again मैं समझाने के लिए एक स्टोरी सुनाती हूँ. फिर से आज आप किचन में हो, आपने मम्मा से कहा मम्मा छन्नी छोटी मत रख के जाया करो, जब जाना है तो छन्नी थोड़ी बड़ी रखा करो. This time she has kept a sieve which has big pores. But this time there's a lot of cream in the channi, lot of malai in the channi. So what will happen when you drain the milk? Again, it will take a longer time for the milk to get drained because the pores are now blocked by something abnormal. So this RBCs, these blood cells are acting as cream or malai in the channi. Is that clear, friends? Am I clear? So what is the secondary open angle? The angle is open but blocked by abnormal material. But blocked by abnormal material in the angle. Guys, is it clear? ठीक है, ये समझ में आता है? Now what is another example of this secondary OAG? कल हमने पढ़ा था phacolytic glaucoma. Phacolytic glaucoma. Do you remember? Phacolytic glaucoma. Where have we read that? It is a complication which is seen with Morgagnian HMSC. Morgagnian HMSC. Yeah? Now again I'm coming back to that. Please see, in Morgagnian HMSC we have seen that the nucleus is settled down and you have a liquefied cortex. Do you remember? And the later on, what change occurs? Please see, all of you. I'll give you time to write. In Morgagnian HMSC, gradually there will be development of small pores. छोटे 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 छेद बन जाते हैं, छोटे छोटे छेद बन जाते हैं कैप्सूल में. When there are small pores in the capsule, there is a leak of lens proteins. Lens proteins will leak out. Okay, these lens proteins will leak out, and then this time they will accumulate within the angle. So they are accumulated within the angle. When they accumulate in the angle, what will happen? They will obstruct the drainage of aqueous. So what type of glaucoma can occur? A secondary open angle type of glaucoma. Okay, so in phacolytic glaucoma, you can say the lens proteins leak out and they block the angle. Yes, friends, are you able to understand?